Imagine you're lying in a hospital bed. Someone walks into your room wearing scrubs, checks your vitals, maybe adjusts an IV line, or, helps you with a meal.
Right, and you probably assume that the person doing those tasks is simply doing their job. Right, like just following a straightforward schedule from their manager.
Exactly. But the jarring reality is that the person turning that dial might not actually be legally authorized to decide when or why you get that intervention.
Yeah, it's wild. And if they make a critical mistake, the nurse down the hall who you haven't even seen today could literally be the one who loses their entire career.
It's just a massive, high-stakes transfer of legal risk that patients are completely blind to.
Oh, absolutely blind to it. But for the healthcare workers involved, navigating who is allowed to do that and who ultimately carries the liability, well, that dictates every single minute of their shift.
And that is the mission for this deep dive. Today, based on our source material, we're looking at the concept of delegation in nursing.
Yeah, we're going to unpack the framework known as the Five Rights, explore the incredibly strict boundaries of the nursing scope of practice, and, reveal how this invisible process is the true linchpin of patient safety.
Okay, let's unpack this. What makes delegation in a hospital so uniquely dangerous? Because, in the corporate world, delegating just means handing a spreadsheet off to a junior analyst.
Right,
And
exactly.
if they mess up, you just fix the spreadsheet. No harm done.
Yeah, but in healthcare, you're dealing with a highly regulated legal framework where actual human lives are on the line. Delegation in nursing is defined as a licensed nurse transferring the performance of a selected nursing task to a competent individual.
The performance of the task.
Yes, but the crucial part of that definition, like the absolute center of gravity for this entire topic, is that the nurse retains full accountability for the outcome.
So they transfer the physical act of doing it, but never the ownership.
Exactly. You delegated the doing, but you kept the liability.
I want to pause on that because our sources make a massive deal out of differentiating delegation from an assignment.
Oh, yeah. They're very different things.
Right, because if an RN hands off 4 patients to another RN at the end of a shift, they aren't retaining accountability for those patients overnight, are they?
No, not at all. That is an assignment. The National Council of State Boards of Nursing makes a very sharp distinction here.
Okay, how so?
So an assignment is the routine distribution of work within a caregiver's own existing scope of practice. When an RN gives patients to another RN, they are passing the baton to someone with the exact same license, training, and legal authority.
Got it. So it's horizontal.
Yes, exactly.
Yeah.
Delegation, by contrast, crosses the scope of practice boundary. It moves vertically.
Like downward.
Right. It's an RN handing a task down to an LPN or a UAP, which is an unlicensed assistive personnel, like a CNA or a patient care tech.
And those people don't have the same legal standing.
Exactly. Those individuals are not legally authorized to perform that task based on their own independent professional judgment.
Okay, so an assignment is like splitting a group project with a classmate where you both get the same grade.
Sure, yeah.
But delegation is like a master architect hiring a builder. The builder swings the hammer, but if the roof collapses, it's the architect's license on the line because, well, they designed the structure and approved the builder in the first place.
That architect analogy maps perfectly onto the legal reality.
Yeah.
The architect made the initial assessment that the ground was stable and the builder was competent.
Right.
If the builder builds exactly what they were told and it fails, the architect is accountable for that flawed initial decision. And that brings us to the ultimate conceptual wall in nursing.
Which is?
Nursing judgment itself can never be delegated, period.
Let me push back on that for a second, though. Let's say you have a CNA who has worked on a cardiac floor for 20 years.
Okay, very common.
Right. They know the rhythms, they know the patients, they've literally seen it all. Meanwhile, you have a day one, brand new RN. Why can't that seasoned CNA exercise some clinical judgment? Experience has to count for something.
Well, experience makes them incredibly valuable, obviously, but it does not alter their legal scope of practice.
The law is the law.
Exactly. Assessing a patient's baseline, evaluating how their condition is evolving, and synthesizing data into a clinical plan of action, those are protected acts of nursing judgment.
So they belong strictly to the RM.
Yes. The state legislature binds those specific acts to the registered nursing license. You can delegate the collection of data, but you can never delegate the interpretation of that data.
Wow.
Yeah, the moment someone tries to pass clinical reasoning over that conceptual wall, you have a catastrophic delegation failure.
Okay, but knowing that this wall exists, how do nurses actually navigate it in the real chaotic minute-to-minute world of an emergency room or a busy med-surg floor?
It's definitely not easy.
Because you can't exactly pause a code blue to go consult a legal textbook, you know?
No, you definitely can't. They were living on a specific framework.
And what I found wild in our sources is that this framework didn't just appear out of nowhere. It was forged in the middle of a massive historical crisis.
Yeah, through the late 1980s and into the 90s, the American healthcare system was undergoing a seismic structural shift. Managed care was aggressively pushing down reimbursements.
So hospitals were losing money.
Right, and they were facing severe nursing shortages alongside these massive cost-cutting pressures. So, to keep the doors open, hospital administrators drastically restructured care delivery.
What did they do?
They flooded the floors with unlicensed assistive personnel to absorb tasks that were previously done exclusively by RNs.
Which sounds like an absolute legal nightmare if the boundaries aren't clearly drawn.
Oh, it's chaos. The Nurse Practice Acts across various states had been written for an older, more traditional staffing model.
Right, where RNs did mostly everything.
Exactly. Suddenly, RNs were being asked to manage these large teams of unlicensed workers, and state boards had very little concrete guidance on what a nurse could legally hand off without abandoning their legal duty of care.
So everyone was just guessing.
Basically, nurses were terrified of losing their licenses, and management was demanding clinical efficiency. That friction forced the NCSBN to publish a foundational position paper in 1995, clearly defining delegation.
And that is where they introduced the famous mnemonic, the Five Rights of Delegation.
Yes. And what's fascinating here is how the authors engineered this framework. They deliberately modeled the Five Rights after an older, already famous pedagogical tool in nursing.
Oh, right, the rights of medication administration.
Exactly. The rights of safe medication administration, right patient, right drug, right dose, and so on. They borrowed that structure because it was incredibly effective at taking an abstract legal principle and distilling it into survival math.
It gave them the quick checklist.
Yeah, a rapid mental checklist they could run through in a high-stress environment. And then 10 years later, the American Nurses Association joined in with a joint statement, fully aligning the ethical standards of the profession with the disciplinary authority of the state boards.
Let's get into the mechanics of these five rights, because seeing how they apply to real patients completely changes how you view hospital care.
It really does.
So the first one is the right task. The source material notes these should be standardized, low-risk, predictable tasks. But honestly, isn't a blood pressure check just a blood pressure check?
Do you think so, Ray?
Yeah, I mean, the cuff inflates, it spits out a number. Why does this require a legal framework?
Well, a blood pressure check is mechanically identical every time, but the clinical context alters the legality of delegating it.
Okay, give me an example.
Taking routine vitals on a stable patient who is ready to be discharged is a textbook delegable data collection task. But imagine that same patient is suddenly shivering, their skin is pale, and their heart rate is spiking.
Uh-oh.
Right. In that moment, taking the blood pressure is no longer just gathering data.
Because recognizing that the patient might be going into septic shock requires interpreting what those numbers mean in real time.
Exactly. Interpreting a deteriorating trend and deciding if immediate medical intervention is required, that is a protected act of nursing judgment.
So the CNA can't do it then?
The CNA can physically wrap the cuff around the arm, sure, but the RN must be the one deciding what that falling blood pressure signifies. The task might look the same, but the risk profile has entirely shifted.
Which naturally bleeds into the second pillar, which is the right circumstance. The same task might be perfectly legal to delegate on Tuesday, but grounds for losing your license on Wednesday if the patient's condition changes.
Circumstance dictates everything. Consider checking a blood glucose level with a simple finger stick. On a stable medical floor, trained UAPs do this constantly.
Very routine.
Super routine.
Yeah.
But what if the patient is in the middle of a diabetic ketoacidosis crisis?
Oh, wow.
Yeah, their blood sugar is wildly fluctuating, their metabolic state is actively evolving, and they're probably on an insulin drip.
That simple finger stick is suddenly the linchpin of a life-or-death medication adjustment.
Exactly. It requires RN-level pattern recognition to safely manage that dynamic situation. You can't delegate it.
Right.
Another classic example is ambulating a patient, walking them down the hall to the bathroom.
Seems simple enough.
Totally standard task for a nursing assistant. But if that patient is 6 hours post-hip replacement and they are exhibiting signs of new orthostatic hypotension, meaning their blood pressure bottoms out when they stand up, the circumstance demands that an RN manage that mobility.
Here's where it gets really interesting, though. Let's say you have the right task and a stable circumstance. You still have to navigate the third right, which is the right person.
Yes, the person matters immensely.
Because verifying competency isn't just looking at someone's job title.
Yeah.
Taking vitals isn't a universally applied skill, right?
Not at all. You might have a CNA who is perfectly checked off and highly skilled at taking standard vital signs on an arm. That does not legally authorize them to pull vital signs from a complex, invasive arterial line.
Oh, that makes sense.
The label of the task, Get Vitals, sounds identical, but the specialized skill and knowledge required are vastly different.
The sources gave a striking example of this happening in long-term care facilities with tube feedings. It seems like a massive trap for nurses.
It really is. It is frequently cited in state board disciplinary reviews. In many jurisdictions, a trained UAP is allowed to administer an established routine tube feeding to a stable resident.
Because it's predictable.
Exactly, it's predictable. But almost none of those jurisdictions permit an unlicensed person to initiate a brand new feeding, or troubleshoot a clogged tube, or manage a resident who suddenly starts aspirating fluid into their lungs.
And nurses fall into this trap because they mentally collapse all those nuances into one generic bucket labeled tube feeding.
Yes, that happens all the time.
They just assume if the UAP can do part of it, they can handle the whole process.
And by doing that, they violate the standard of care by handing off the troubleshooting, which requires clinical judgment. And that brings us directly to the communication aspect. The fourth right is right direction and communication.
This one seems straightforward, but I imagine in a fast-paced environment, it gets incredibly sloppy. Like, why can't a charge nurse just look at a tech and say, hey, keep an eye on the guy in room 4, he's acting weird?
I mean, people do say that, but from a liability standpoint, keep an eye on him is legally indefensible.
Yeah, because it's too vague.
Way too vague. It provides no parameter for success or failure. Proper direction means specifying exactly what task to do, precisely what data to collect, and setting crystal clear parameters for when to report back.
So how should they say it?
You have to tell the UAP, check his blood pressure every 15 minutes.
Yeah.
And if the top number drops below 90, come find me immediately.
Ah, I see.
You don't leave them guessing whether they should report it now or just write it on the chart at the end of their shift.
Which implies that the nurse actually has to follow up. You can't just throw tasks over the fence and assume they get done.
You definitely cannot.
And according to the sources, that is the single most violated rule. The fifth right, right supervision and evaluation.
Supervision is the critical mechanism that turns delegation from a dangerous one-off transaction into a continuous safety loop. The delegating RN must follow up.
They have to close the loop.
Exactly. They have to verify the task was completed correctly, evaluate the patient's resulting condition, and remain physically or practically available to intervene if something goes wrong.
And if they don't?
Handoffs without follow-up are, by definition, an abandonment of supervision. It is the leading reason state nursing boards discipline licenses for negligence.
Wow. You know, the 5 rights sound like a highly logical, foolproof checklist on paper. But they aren't executed on paper.
Far from it.
They're executed in an environment of intense friction. Which brings us back to the economic reality you mentioned about the 90s. This isn't just a safety framework, it's a financial battlefield.
It absolutely is. Delegation is celebrated as a clinical efficiency tool because it frees up the RN to focus on high-level judgment. But hospital administrators know it is undeniably a cost containment lever.
Because unlicensed staff are cheaper.
Significantly cheaper than paying registered nurses. That financial reality creates a massive conflict between management's budget and the nurse's legal license.
So an understaffed hospital has a huge financial incentive to stretch delegation to its absolute breaking point, pushing nurses to hand off more than is actually safe just to survive the shift. How do nurses fight back against that kind of systemic pressure?
Well, labor unions within the nursing profession developed a specific tool for this called the Assignment Despite Objection Form, or ADO.
What does that do?
So when a nurse is handed a patient load that is mathematically impossible to manage without wildly over-delegating tasks and abandoning proper supervision, they fill out this form.
It's like a paper trail.
Exactly.
Yeah.
It allows the nurse to formally document in real time to management that they are accepting the assignment because refusing it outright could be construed as patient abandonment.
Right, which is also bad.
Very bad. But they are going on the record stating the conditions do not allow for safe adherence to the five rights. It is a paper shield against liability.
That friction between safety and efficiency leads to two distinct failure modes. The first is over-delegation. We've touched on this, handing off tasks with hidden clinical judgment or failing to supervise.
Right, and that gets your license suspended.
But the second failure mode completely flipped my understanding, under-delegation.
Yes.
If a nurse decides the environment is too chaotic and they just do everything themselves out of an abundance of caution, isn't that inherently safer for the patient? I mean, they're controlling the entire process.
It seems highly logical, and honestly, many nurses fall into this trap out of a fear of liability.
Or like a super nurse complex.
Exactly, a sort of martyr complex where they feel giving away tasks is a sign of weakness. But underdelegation is actually a catastrophic failure of care management.
Walk me through the mechanics of why that fails.
It comes down to a sheer lack of bandwidth.
Hmm.
If a highly trained critical care RN spends 2 hours of their shift performing routine bed baths and pulling standard vital signs tasks, a CNA could execute perfectly. That is, 2 hours they are actively neglecting something else.
Like what?
The complex assessment, medication titration, and clinical reasoning tasks that only their license allows them to do.
Oh, wow. I didn't think about it that way.
By hoarding the low-risk tasks, they are literally starving the patient of high-level medical judgment. Furthermore, it drives severe burnout. A nurse cannot function as a one-person healthcare system.
The psychological pressure of this environment breeds some incredibly pervasive myths. I want to rapidly dismantle a few of the core misconceptions detailed in the research because understanding why these myths persist really crystallizes how delegation impacts the care you receive.
Let's do it.
Myth number 1, once I delegate it, it's not my responsibility anymore.
This myth is born from corporate conditioning, where delegating a project removes it from your desk.
Right.
In nursing, it is the single most litigated misunderstanding. Accountability never transfers. The state board views the RN as legally answerable for the initial decision to delegate, the competency of the person they selected, and the adequacy of the supervision they provided.
So you delegated the doing, you kept the liability. Okay, myth number 2. There's a fixed list of delegable tasks. I think the general public assumes there is just like a laminated poster in the break room dictating exactly what a tech can and cannot do.
A static list cannot account for dynamic human biology.
So it changes based on the patient.
Absolutely. A complex wound dressing change might be safely delegable for a healthy patient on Monday and completely non-delegable for the patient in the next bed who has a compounding infection. The 5 rights demand a fresh, situational analysis for every single patient interaction.
That makes sense. Myth number 3, delegating means you can't handle the workload, so you're sloughing it off on the techs.
We see this deeply ingrained in nursing culture, but it is entirely false. Appropriate strategic delegation is a mandatory clinical competency.
It's part of the job.
It is a leadership skill. As we discussed with underdelegation, failing to distribute the workload is what actually jeopardizes the patient's life.
And finally, myth number 4, if the UAP makes a mistake and drops a patient, the UAP is solely liable for the lawsuit.
Liability in these cases is bifurcated. It is not an either-or situation.
So they both get sued.
Pretty much. The unlicensed assistant is absolutely accountable for performing the task correctly as they were trained to do. However, the delegating RN carries separate liability for poor judgment in deciding to hand off the task, or for failing to supervise the assistant. Both individuals can find themselves facing legal consequences for a single mistake.
Wow. If we pull back and look at the macro impact of this, why is this invisible legal dance so critical for the future of healthcare?
If we connect this to the bigger picture, we are standing on the edge of a massive demographic cliff.
The baby boomers aging.
Yes, we have a rapidly aging global population, surging rates of chronic, complex diseases, and persistent systemic nursing shortages that are only projected to worsen.
So the math simply dictates that a shrinking pool of registered nurses is going to have to manage an expanding ocean of patients.
Precisely, which means the proportion of daily, hands-on patient care performed by unlicensed assisted personnel is going to skyrocket.
That's concerning.
Getting this delegation process right, ensuring that nurses can safely scale their clinical judgment across teams of unlicensed staff, is the only way modern healthcare survives. If the 5 rights framework collapses, the quality and safety of the entire system collapses with it.
So what does this all mean for you, the listener? To recap our deep dive, you can transfer the performance of a task, but you can never transfer the ownership of a medical license.
Never.
The five rights task, circumstance, person, direction, and supervision are a living, breathing risk assessment process, not just a static checklist you memorize in school. And most importantly, the critical act of interpreting data and making clinical judgments remains the exclusive, legally protected domain of the nurse.
And looking forward, this framework faces an existential challenge. Critics are actively debating how the 1995 rules apply to modern technology.
Oh, interesting. Like what?
As healthcare rapidly decentralizes into models like telehealth and remote home health monitoring, how will the system guarantee that crucial fifth right, or supervision?
Oh, because they aren't even in the same room.
Right. How does a delegating RN truly evaluate the competency and actions of an unlicensed home health aide when that nurse is staring at a computer screen 50 miles away from the patient's living room?
That is a phenomenal, unsettling question, and solving it is going to dictate the safety of healthcare for the next generation. The next time you or a loved one are sitting in a clinic and someone walks in to check your vitals, remember the intricate legal machinery operating right in front of you. Keep questioning the invisible systems around you. Thanks for joining us on this deep dive.